Good afternoon, everyone. First of all, I would like to thank the organizers for giving me this opportunity. My topic today is multimodal imaging in single ventricle palliation. Some introduction of the single ventricle and the strategies for managing this patient, merits and demerits of each imaging modality, role of imaging in interstage, what is the current evidence, practice in our unit, and some examples how imaging was used in our unit in the interstage palliation. As you all know, common types of single ventricle we come across are tricuspid atresia, pulmonary atresia with intact septum and severely hypoplastic right ventricle, unbalanced AV septal defect, double inlet left ventricle, hypoplastic left heart and spectrums. And occasionally in some patients, the ventricular septal defect is very large that the heart cannot be septated. These stages of palliation, the stage 1 will depend whether there is systemic outflow tract obstruction or there is a substrate for developing it. If the answer is no, then the management would be BT shunt or ductal stent for those with restricted pulmonary blood flow, or pulmonary artery band for those with unrestricted pulmonary blood flow. When it is hypoplastic left heart and spectrum, the first stage palliation is Norwood procedure, which involves Damascus stanza anastomosis and arch reconstruction. And to secure the pulmonary blood flow, either BT shunt or RV2PA Sano shunt is performed. The DKS anastomosis involves creating a neo aorta from pulmonary artery, and native aorta is connected to the neo aorta. Stage 2 is bidirectional Glenn, where superior vena cava is connected to the pulmonary artery. In patients with bilateral superior vena cava, bilateral bidirectional Glenn is performed. And in those with interrupted IVC with assegus or hemiassegus continuation to the upper body vein, Kawashima operation is performed, where in the stage 3, the hepatic veins are also routed to the pulmonary arteries. Stage 3 is completion of the total cavopulmonary anastomosis, which is also known as Fontan operation. This is performed with or without fenestration. And in our unit, we assess the need for fenestration on a case-by-case basis. We have Y-graft Fontan is very rarely performed. In our unit, we commonly perform extracardiac Fontan. The atriopulmonary and lateral tunnel Fontan are no longer performed, but we do come across these patients in the follow-up. And in patients with abnormal lie of the heart and isomerism, we have performed few intra-atrial Fontan graft, where the graft runs through the atrial mass. Comparing the imaging modalities, as you know, the echo, cardiac MRI, CT, and cath are the commonly used modalities. Echo includes transthoracic, transesophageal, and 3D echo. It is excellent for valve assessment, both for quantification and understanding the mechanism of stenosis and regurgitation. Cardiac MRI is robust for assessment of ventricular function, tissue characterization, and it also gives flow data. Cardiac MRI, CT, and cath can all give anatomical information, but CT and cardiac cath will involve exposure to radiation. Cardiac cath will need general anesthesia in children, and cardiac MRI also in children less than 8 or 9 years of age will need general anesthesia. CT in our unit in patients less than 4 or 5 months of age, we do it with feed and wrap. And between 5 months and 2 years of age, we give chloral hydrate sedation. Cath can provide hemodynamic data, and in single ventricle patients, we are particularly interested in mean pulmonary artery pressure, transpulmonary gradient, and ventricular end diastolic pressure. Moving on to imaging before stage 1 palliation. The current evidence is very scant, but most of us will agree that echocardiogram is a powerful tool based on which we can identify the sequential segmental anatomy, and also the management can be planned. Use of other modalities is mostly to confirm the echocardiogram findings. This is an active area of research. So the current practice in our unit is echocardiogram alone in most of the patients. CT angiogram is performed to assess the ductal morphology for suitability of stent. In all isomerism patients, we perform CT angiogram, and if there is suspected anomalous pulmonary veins, we do CT angiogram to confirm the echo findings, as sometimes there can be surprises. And if pulmonary artery or arch anatomy is not clear on echo, then we go ahead with CT angiogram. Cardiac catheterization is very rarely performed. You can think of one instance where we have used is patients with pulmonary atresia intact septum, and echo evidence of RV-dependent coronary sinusoids. We performed cath to confirm this, to see whether the RVOT obstruction can be relieved. MRI is very rarely performed, and in some instances when there's a borderline ventricular size, we have, for example, patients with unbalanced AVSD and borderline left ventricle, we have performed. And the evidence for this comes from this paper from sick kids, wherein they did MRI for those patients with borderline left ventricle, and they concluded that if the LV end diastolic volume is more than 20 ml per meter square, those patients can undergo biventricular repair with less complications. They also use the ascending aorta flow data to predict patients who can have successful biventricular repair. These are some examples of patients where we did CT angiogram before stage 1 palliation. So this patient had unbalanced AV septal defect with pulmonary atresia. The CT was done for ductal morphology. As you can see, the duct coming out the undersurface of the arch, and it has a straighter course, and this patient underwent successful ductal stent. This patient had very complex single ventricle anatomy. The echo showed total anomalous pulmonary venous drainage, and hence CT was performed. CT showed a complex total anomalous pulmonary venous drainage, where right upper pulmonary vein was draining into the left superior vena cava, with the ascending vein crossing the midline, and the other pulmonary veins were draining below the diaphragm. There was also an unusual communicating vein between the right upper and the right upper and left upper pulmonary vein. This is a patient with right atrial isomerism. You can see bilateral right atrial appendage morphology. This patient also had the pulmonary veins formed a confluence where drained into right-sided atrium. Inferior vena cava was draining into the left-sided atrium. The anatomy was unbalanced AV septal defect with RV hypoplasia. As you can see, the duct has a very tortuous course, so the patient was considered not suitable for ductal stent and underwent a BT shunt. So this is a patient with very rare anatomy of double inlet right ventricle. So you can see in the short axis, the posterior ventricle is hypoplastic. The echocardiogram showed unusual arch anatomy, and hence we did CT angiogram, which confirmed a rare association of double aortic arch in the setting of double inlet right ventricle. Moving on to imaging before stage 2 palliation. The current evidence, this study comparing the cardiac MRI and echocardiography in 37 hypoplastic left heart syndrome patients from Great Ormond Street group before bidirectional Glenn showed that MRI does not add anything significantly more than echo if the ventricular function is normal. The anatomical abnormalities detected by the cardiac MRI can be imaged by CT without general anesthesia. This paper from the Boston group study comparing the cardiac cath and MRI in 82 patients with no baseline differences between the groups showed that there was no difference in immediate postoperative course and clinical status, or the need for reinterventions at the 3-month follow-up. This is a retrospective review of echo and cath data, again from the Boston group. In single ventricle patients, they concluded that there is no benefit of cath except for identifying anatomical abnormalities, which can be easily delineated by CT angiogram. So there is no The only small studies that have shown that CT has high specificity and sensitivity as compared to the surgical findings, but no long-term data is available. There's no study comparing CT and echocardiogram, and cath hemodynamic data does not have any added benefit. And in our unit, we have not rejected any patient for bidirectional Glenn based on the hemodynamic data in the last 10 years. So the current practice prior to stage 2 palliation, echocardiogram alone in some patients. We assess for the adequacy of atrial communication, and atrial septectomy is performed at the time of Glenn if there is restricted communication. CT angiogram for all patients with hypoplastic left heart palliated with Norwood Sano, and all single ventricle patients with shunt and ductal stent, and only few patients with pulmonary artery band if there are concerns on echocardiogram. And CT angiogram, we perform if the question is the assessment of rootability to see if the patient can be converted into a biventricular repair. And if both rootability and ventricular volume function is a question, then we do cardiac MRI. Cardiac cath is very rarely performed. All our hypoplastic patients with Norwood Sano palliation, they stay as inpatient in the interstage between stage 1 and 2. And we perform weekly echocardiogram. And this patient during the monitoring was found to have progressive right ventricular systolic dysfunction and progressively worsening tricuspid regurgitation. Some other examples. So this is a pre-Glenn CT, showed the distal end of the Sano has caused some distortion of the pulmonary artery, especially the LPA origin has significant stenosis. We frequently come across discrepancy in the arch size between the neo aorta and the arch, which generally we do not do any intervention. But if the question is the coarctation of aorta, then it is fixed at the time of bidirectional Glenn. So this patient, this is a CT pre-Glenn, and a patient with hypoplastic left heart palliated with Norwood Sano. So you can see the CT images very clearly show the Damascus stancil anastomosis, and even the coronary arteries are very well seen. You can see the proximal Sano anastomosis, and the distal Sano anastomosis has caused some distortion of the origin of the branch pulmonary arteries. And there is proximal right pulmonary artery hypoplasia as well, which has to be fixed at the time of bidirectional Glenn. So, so this patient had cardiac MRI as a workup before Glenn. The underlying anatomy was aortic atresia, ventricular septal defect, had Norwood Sano as a first procedure. The MRI was done to assess the LV volume and also to assess the rootability for SE procedure. So the LV volume was adequate, and the VSD, as you can see here, was thought to be adequate for the routing the left ventricle to the neo aorta. This patient had successful SE procedure. Moving on to imaging before stage 3 palliation. When it comes to investigations before Fontan, many centers, including ours, do cardiac cath. Now the question is it really useful in management and outcome? So this retrospective study from Boston, including 175 patients, concluded that cath hemodynamic data was not associated with early postoperative outcomes. They had some minor complications and very rare major complications, which has to be factored. We concluded that at least 50% of the patients we can avoid cardiac cath safely, but adequate non-invasive imaging should be performed, and echo alone is not sufficient. So either cardiac MRI or CT. So the same Boston group came up with this algorithm wherein they propose some high-risk characteristics based on the history, echocardiography, and angiography. And if you have more than one high-risk characteristics, then those patients went on for cardiac cath. No high-risk characteristic, they directly had Fontan operation. So 63% of 151 subjects had low risk factors. 37 had high risk, and 9 of 151, which is 6%, were deemed inoperable after cardiac cath, and all 9 were classified as high risk by the algorithm. And this algorithm also predicted adverse postoperative outcomes with sensitivity of 51% and specificity of 78%. But adding the hemodynamic data to this algorithm did not increase this prediction. So cath hemodynamic data, so no significant correlation between pre-op hemodynamic data and short-term outcome is available. Hemodynamic data rarely changes the management strategy, and decision for cath should be based on clinical and non-invasive imaging findings in individual patients. So in the current practice, the echo we perform for valve regurgitation, degree and mechanism, and ventricular function. Cardiac cath for most of our patients for anatomy, hemodynamic data, and interventions as required. In the last 1 year, we have avoided doing cath in few patients, but we perform CT and MRI. So we frequently do combined imaging where MRI or CT is also done at the time of cath, and also we carefully assess the patients at the time of Fontan for conversion to 1.5 ventricle or biventricular repair. So if the ventricular volume, function, and rootability is questioned, we do MRI. If the question is only rootability, then we choose CT angiogram. We also do transesophageal echo at the time of the general anesthesia for assessment of valve regurgitation, the mechanism. And in patients with rootability, we assess the AV valve for any straddling. So some examples. So this patient had truncus arteriosus, but significantly hypoplastic left ventricle, had bidirectional Glenn, but between the Glenn and Fontan, the right ventricular systolic function was worsening. MRI was performed, and which showed the RV ejection fraction was only 10 to 15%, and there was also moderate truncal valve regurgitation. This patient was considered not suitable for Fontan and was referred for a heart transplant. Another example, so this patient had right atrial isomerism, unbalanced AVSD, and pulmonary atresia, aorta coming up the right ventricle, and moderate AV valve regurgitation on echocardiogram. MRI was performed for quantification of the valve regurg and anatomy. The AV valve regurgitation fraction was 38%, which is moderate to severe, and hence the valve was repaired at the time of Fontan. And the MRI also showed pulmonary AV malformations in the right lower lobe, which explain the patient's low saturation after the Fontan. Another example, so this patient had atrial situs inversus, AV discordance with ventricular septal defect and pulmonary atresia, aorta coming up the right ventricle, previously had bilateral bidirectional Glenn, and this CT was performed for assessment of biventricular repair. We chose CT because the echo showed the RV volumes were on the, meaning RV size was smaller, hence we decided to leave the bidirectional Glenn and only do hemimustard with Rastelli. So that is the baffling of the inferior vena cava and the pulmonary veins, and the Rastelli. The VSD was considered adequate for Rastelli procedure, and this patient underwent successful surgery. Imaging post-Fontan, we commonly use cardiac MRI or CT. Our practice is routinely do cross-sectional imaging at around 15, 16 years of age before they are transitioned to the adult care. Earlier, if there are any concerns on the echocardiogram or the echo does not show the structures very well, we mostly use cardiac MRI and very rarely CT, as these patients are very old and they cooperate well without general anesthesia. And as you can see in the slide, we monitor for these complications. And in patients with Fontan failure, we do combine cath and cardiac MRI. So these are some nice images that CT can provide of the entire TCPC circuit. And for cardiac MRI, when assessment of rootability and follow-up, we do 3D balance SSFP sequence. This is one of the example where you can see the intra-atrial Fontan graft running through the atrial mass. Just one final example. So where this patient developed protein-losing enteropathy following Fontan, 12 years old with double outlet right ventricle with transposed great arteries and pulmonary stenosis. So we performed MRI for RV volume and assessment of rootability of the VSD. As a RV volume was too low, this patient underwent tracheostomy and with a takedown of Fontan, and the Glen was left alone. So you can see the 3D balance SSFP multiplanar reconstruction. The VSD was slightly on the smaller side, and hence the rastery was performed with the enlargement of the VSD. And follow up, this patient's PLE reversed. So conclusion, multimodal imaging is needed for comprehensive management of single ventricle patients. Each modality has its merits and demerits. There is paucity of data to substantiate the role of cardiac cath prior to stage 3 palliation, and adequate non-invasive imaging should be performed to identify those who would benefit from cardiac cath. Combining imaging modalities under same anesthesia can be very helpful, and multi-center randomized controlled trials are needed in the future to identify the role of each imaging modality in the interstage evaluation and long-term follow-up. I think the future will be combined X-ray, cardiac cath, and MR lab, which some of the centers already have. Thank you.